Good morning, everybody. Welcome to our breakout session. We're going to begin in a couple of seconds. Thanks for joining us this morning. We'll give it a 30 more seconds and we'll get started. All right. Good morning, everybody, and welcome to our breakout session. It's called Integrated Practice Units and Remote Patient Monitoring, Advancing Excellence in Patient Engagement and Care. Now, if this is not the breakout session you're looking for, please message us and so we can help you get to the right breakout session for you. You can use the chat box for that. While we wait for people to switch into breakout rooms, we want to hear from you. So let us know in the chat box, where are you joining us from? We're expecting people from all across New York State to be joining us today. So we're just curious to know where you're from, where you're joining us from. When you use the chat box today, please make sure to select everyone in the drop down box so we can all see your message. You can also use the chat box to ask questions throughout today's session. And we'll get to those questions at the end of the presentation. So I don't want to take up too much time, so let's get right to it. I want to introduce our great friends from WestMed Medical Group, and I am going to hand it over to Dr. Kaliag. Thank you very much.
Hi there. Thank you, Mark, for having us here today. And thank you to Lisa Neff and the American Heart Association. We're really excited today to present on some of the initiatives we've been working on this year. Coming out of the pandemic, I think it's refreshing to be able to have found positives that we learned from our patients and our staff and our physicians. That was a trying time for all of us, but actually there were some good things that came out of it. So before I start, I'd like to introduce our team and WestMed. I am Dr. Patricia Kaliag. I am the Chief Medical Officer for WestMed and actually an OB by trade. Dr. Sandra Kesh is our Vice President and Chair of Population Health and Infectious Disease. We will have on screen shortly Althea Matthews, who's our Clinical Operations Director, Project Management for this particular initiative, and Diane Pagan, nurse practitioner and director of complex care. In the room with us is also Rebecca Graziano, who did our beautiful marketing for this project. WestMed is an outpatient multi-specialty group with about 350,000 patients, 1.3 million annual visits. The important part of that is that we have a very large primary care practice, 192 primary care providers, 160 specialists. We are a level 3 patient care medical home organization, and for us, American Heart Association Target BP Gold status holders. We have over 120,000 internal medicine patients that have us as their primary care physician, and well over 18,000 patients with hypertension. And hopefully, after our programs have been running through, that number should come dramatically down, at least certainly the amount we have in control. So what is remote patient monitoring? For those of you who are not familiar, it is the use of Bluetooth-enabled home monitoring devices to allow real-time health data to feed to WestMed providers and care coaches when patients are outside the clinical setting. So the why did we decide to get into this area? As we came out of the pandemic, where we had really been forced to train our patients, physicians, and staff on digital tools to communicate, we realized that we got a lot of uptick. In fact, it was impressive that we completely converted as many organizations did, our patient visits from 5 to 10% digital to 90% digital. With that, we understood this is a critical tool. We learned a lot during the pandemic, difficult as it was, and realized that it was time to open our digital front door, to use it to help us with several objectives that we have in 21, which is to improve patient engagement, to begin reaching patients in between the visits and in their homes, to optimize use of digital tools, and what has always been an objective, to improve outcomes and bend the cost curve. So remote patient monitoring really presented for us an excellent strategic opportunity to fulfill many of the pillars of our organization. As you can see from our slide, we have used these Bluetooth-enabled devices, which I'll show you a little bit more down to the next slide of which ones we're using, to have our patients be able to send data to us between visits automatically. Additionally, another really promising part of this program was the improvement in patient engagement. Because we are using virtual care coaches to reach out to these patients, it really helped us in a time where the labor pool is somewhat shrinking. Having the use of a virtual workforce is another key element that I think we're all going to be moving to. People are used to working from their homes now, and to the extent that we can leverage those individuals who are interested in healthcare and participate in this virtual care coach program, it could really help our patients. We live in a very busy area. We have a very, very large practice. Access to physicians is sometimes impeded with communication through contact centers and such. And a lot of communication has now been done through email. So with the help of the virtual care coaches, patients have an individual identified care coach for themselves. So that care coach is a critical now connection to WestMed that helps facilitate their ease of reaching us, and also their ability to provide direction to basic education that we're providing, to emphasize our goals of understanding your chronic condition and understanding the importance of your medications and taking them. While they cannot answer medical questions, they can direct people to our sites and provide the encouragement of why we are approaching this program, why it's important to keep track of your blood pressure in this program, and how they can reach their physicians. Additionally, what we looked at when we started was, of course, it sounded like a great idea, but had it been proven in areas? And we saw that in early literature, even as early as 2014 and 2012, there were articles coming out that were showing in the literature that with the Geisinger Health System plus others, that they were seeing a reduction in all-cause admissions, which is tremendous, in addition to other patient experience metrics. And we thought, let's take a look at it. So we started interviewing vendors, which is an interesting process. There are a lot of vendors out there, and at any point, if you ever want to reach out to us individually to have you help you through it, we certainly would share our knowledge. We are looking in this program to look at diabetes, hypertension, chronic obstructive pulmonary disease, and obesity. So we actually have different vendors for the disease management and mostly for the level of care that people would need. In our hypertensive patient population, for those that are not heavily involved, or complex care patients, we're using a program that uses a virtual care coach that is not necessarily a nurse or nurse practitioner. For our sicker patients, that we will be launching a program using virtual care of nurse practitioners who can interface with our sicker patients, and that's been shown to have dramatic difference in hospitalization rates. So our program is definitely one that is building, and we began it and actually had a lot more patient engagement than we expected. Again, what we are speaking to the patients about is how this is meant to help improve their outcomes. We're teaching our physicians the same thing, that patient engagements and the use of care coaches are key, and reduced hospitalization is helpful. You can hold that slide. So what was important in the whole development of this, and what was surprising, is we used a company that was kind of learning as we were. There are certainly vendors out there who have this turnkey for you. A lot of how we wanted to do it, since we were learning, was work with a company that would allow us to have kind of more control of the process, so we could tailor it to what we thought our needs were, what our physicians felt comfortable with relinquishing to the virtual care team, and what our staff felt comfortable with. There are positives to using a company that's kind of early on in their development, and there are challenges, and Diane will speak to those. So you can go to the next slide now. In addition, something that everyone should realize, this service, at least through Medicare, is a covered service, which is terrific, because while we understand that it's meant to improve outcomes and bend the cost curve to reduce admissions, it also has a fee-for-service component that can certainly, if the program is operationalized completely, really add to other programs. We realize that this revenue that is brought in, that we can, help patients outcomes, but we can also use this additional fee-for-service revenue to feed into our complex care programs, where we have a much more intensive outreach program that Sandra will be speaking about. So in sum, before I let Althea and Diane take you through kind of the granular aspects of it, what we believed was this was perfect for our overall patient engagement strategy. As we are passing through 2021, going into 2022, we really wanted to increase our digital footprint, open the door, digital acquisitions. We wanted a program that would be physician-led. Our providers are very, very intimately involved with their patients and didn't want to turn over some of this all the way to care coaches or nurse practitioners that were outside this organization. So our first foray into it was where we would maintain much more of the control. However, we really do believe, even before we found remote patient monitoring, Dr. Kesh and I were thinking through how we were going to develop our own care coach program. It's really been shown in the literature that having that intermediary, that person who can help explain to patients once they leave the office, it could be critical in improving patient understanding of their disease conditions and compliance with their medications. Additionally, as we were picking a vendor, we were also using someone that we knew had the digital tools to make a, quote, sexy application that patients would be enticed to go and look at for patient education. So we have started this with hypertension. We've done it in obstetrics, we're doing it in weight management. And in that program, it's actually pretty intense, and the patients are really happy with it, as we give scales out to patients to help them manage their weight, and again, connecting them with care coaches and nutrition experts. So overall, it's been a terrific project so far, with certainly some challenges. I'll be completely transparent with you. It's not been easy, but I'm going to have Althea come up now and speak a little bit. Okay, thank you. Oh, I'm sorry. Thank you, guys. Actually, before I have Althea speak, we did put together a fantastic video for our patients that's going to be used shortly. We have actually not put it out yet because our response on our initial outreach to our patients was so strong. Literally, while United Healthcare got 10% of their patients signing on, through our care coaches and our providers promoting the program, we had over 50% sign up in our initial outreach, which actually was a bit overwhelming because we reached out to a lot of patients and people really wanted to participate in this program. So while we prepared this video to encourage people, we actually needed to step back a minute before we sent it out to adjust to the demand. So this will be going out to our patients shortly.
Nowadays, it's easy to stay connected to the things that are important to you. Video chats, social media, email, it's all right at your fingertips. But what about your health? When you visit with your care team, they can really help you get on track. And when you're trying to stay healthy, it's the moments in between doctor visits that really matter most. But when you're managing a chronic condition like diabetes or high blood pressure, it's not always easy. My WestMed Connect makes it so simple. With WestMed's new remote monitoring program, you can use your phone to stay on top of your individual health goals from virtually anywhere. Here's how it works. After you enroll, you'll get a free healthcare device in the mail, like a glucometer or a blood pressure cuff to help you track important vitals. Your device connects seamlessly with a My WestMed Connect app. It even transmits your health readings directly to your doctor's office. You're also connected with a dedicated care coach who helps you set up your device, take readings, and optimize your health. Log into the app, pair your device, and your blood pressure levels will be instantly recorded each time you take a reading. Same goes with a blood sugar check or a pulse oximeter reading. All your readings will be monitored by your care coach and the WestMed team. Together, you'll even have access to tips on healthy eating, exercise, anxiety, and stress relief. Because when it comes to the moments in between office visits, living your best life is what we all care most about. To learn more about WestMed's remote patient monitoring program and how to enroll, visit westmedgroup.com/RPM today.
Great, thank you, Rebecca. All right, so Althea is going to come up and speak a little bit about how we got this program off the ground. Okay.
Thank you, Dr. Kaliak. Hi, everyone. My name is Althea Matthews. I am the project manager here at WestMed. Thank you so much. I'm so happy to be joining on this panel today. It is with a great pleasure and honor to present alongside these women who have made it their mission to deliver exceptional care to our patients. My role from an operations perspective under the direction of Kelly Meny, Director of Operations, is to bring together various stakeholders from analytics, patient experience, clinical management, and marketing to implement remote patient monitoring as a way to manage patient care from outside of the exam room. Dr. Kaliak coined us the dream team. Before I share some feedback on positive outcomes and the challenges faced in the midst of going live with the program, I would like to take a few minutes to speak about the importance of incorporating digital tools to create awareness. We all know wait times when seeing a doctor are on the upswing. By adopting RPM tools, this not only eliminates wait time, but also improves the speed of care and ultimately proven to save lives. Digital tools help providers and patients manage their health and improve the quality of care while making healthcare cost-effective for all from the comfort of their home. So we had two patient clinical wins. I'm going to pass it back to Dr. Kaliak. If these patients were not enrolled in RPM, their outcome would have been different. So I'm going to pass it back to Dr. Kaliak, and then we're going to toss it to Diane.
Pass it back to me to tell of a short story of our brilliant initiation of this program, and maybe not so brilliant. So I'm an obstetrician. So we decided to start the program in obstetrics, the highest risk population that we could have, most acute population to give this to. So that probably wasn't my best choice ever, since we really needed to kind of work out the kinks, and taking the patients that would be most acutely affected with the change in blood pressure, perhaps it wasn't the best. However, we did have some early wins, which were helpful as you bring a new program that requires a cultural shift for the patients and the physicians. It was great to have an early win. So our program was designed to reach any postpartum patient or antepartum patient that had elevated blood pressure. So one of our patients had been discharged from the hospital with her blood pressure cuff and a care coach, knowing because she had had severe preeclampsia in the hospital. She was actually sent home on blood pressure medication. And typically that type of patient in that scenario would not come back to the office for 72 hours. That's kind of the standard of care. This patient went home with a blood pressure cuff and decided probably the first day our program went live to take her blood pressure at around 9 o'clock at night. And I know this well since I was at my daughter's graduation party. Anyway, I start getting phone calls, And I realized, why are people calling me? I better answer. And we had our first alert, which did go properly through to people, but everyone was sort of, a little bit surprised. The doctor was talking to the patient. The patient was saying she felt absolutely fine. Her blood pressure was 190 over 110. The doctor prevailed and was able to get her into the hospital. That blood pressure was correct, and she was 200 over 110 and admitted to the ICU and treated. That was, unfortunate for the patient, but fortunate in the sense that we prevented a stroke in that patient who's a newborn, who's got a brand newborn. So we were pretty thrilled with that outcome. That same night, we had another trigger alert for a pregnant patient who had mildly elevated blood pressures. And in those patients, we are sending them home with cuffs since they are being seen weekly. And, certainly we were still well into the pandemic. Patients were delighted not to have to come in any more than they had to into our offices. Well, that patient, 34 weeks pregnant, picked up an elevated blood pressure when she had been just mildly elevated. That patient was instructed to go to the hospital. And while her visit might not have been for another week, her disease would have progressed. Instead, she was brought in then, and fortunately, it was picked up. And she was able to be given steroids, which are help. This patient had an early pregnancy, help mature the baby's lungs and deliver the baby, rather than, in 48 hours, rather than it being an emergent situation where she showed up and we weren't able to do that. So we were thrilled with those early wins, but also learned that this is a brittle population in terms of hypertension, and had to accelerate our education of our providers. And I emphasize, and I'll say it again later, this program requires a cultural shift for patients, staff, and physicians. For us to have your healthcare metrics, as the video says, be as important as your email and your Instagram is definitely going to take some challenges. Okay, Diane Pagan, thank you.
Hi, everyone. I'm Diane Pagan. I'm a nurse practitioner and director of complex care here at WestMed. So I'm going to review things on a little bit more of a granular level in terms of, I know it was made to sound very easy, this program and implementation using an outside vendor, but there was a lot involved. And I'd like to mention a lot of those points for anyone else who is looking to incorporate a program like this. The criteria which we used for our RPM was the internal medicine patients. And we included patients that had a diagnosis of hypertension. And we also chose patients who were both controlled and uncontrolled. And with that, we were able to address the needs of the older population, which we do have a large population of older patients, 80+ years. And we realized that they do not all have a smartphone or an iPhone. So we worked with the vendor and we were able to incorporate devices that used both Bluetooth and cellular devices so that they didn't have to use an app to download anything. What we did was we put together a team of people, and again, it's the dream team. And I have to say they really were a dream. And I do want to mention some names as I go through a little bit of what each person did, because again, there was so much involvement and coordination of a lot of different moving pieces at all times. So we have Althea Matthews, whom you met, and she's the project manager, and she worked very closely with Kelly Many. Althea was responsible for scheduling meetings. She worked with the vendor. She shared the status of each team member's tasks and then delegated what action item was due and when it was due and made sure we did it. With Kelly Many, she's the director of operations, and she worked very closely with the vendor and with Althea on ordering devices. They strategized the implementation of the RPM dashboard, which all the providers here at WestMed had access to and log in, and they were able to view all of their patients' readings anytime that they wanted. They also handled the accounts receivable, the accounts payable for reimbursement of the devices, and the services rendered by the vendor. Melissa Vega was our Associate Director of Complex Care, and she established the detailed workflows and wrote scripts and assisted in the creation of educational material, the workshops for staff. She educated managers in all the departments so that they can review the program with their nurses, and she managed the day-to-day operations of the project, and she also worked hand in hand with our registered nurse, who is Jennifer Fort, and she was assigned to enter in all of the RPM orders because each one of these devices did need an order from the provider. So she coordinated all of that with the provider to make sure that they knew that their patient was enrolled, the orders were signed, and she sent them back to the company. And she was responsible also for taking the calls from the call center on any patient who had an alert. She had a dedicated phone line, which was set up by Melissa, and she was able to call these patients who had abnormal alerts to make sure that, number one, that they were okay. Number two, did they need an issue addressed? And number three, she scheduled appointments with their primary care provider or their nurse practitioner to bring them in if there was a problem. We had Celia Bertuzzi, who's one of our nursing directors, and she put together all of the educational material that was needed for our patients. And she chose from the robust materials that the American Heart Association has. And that was wonderful. And the patients were able to download and print this material from either online or their phone, their app. Angelica Rivera, who's the director of patient experience, she was able to review the phone calls and some of the conversations between the care coaches of the vendor, as well as the patients. And she was able to provide great feedback both to the vendor and to us so that we can change scripts and we can improve the process overall. Rebecca Graziano is the marketing director, and her team put together all of the content on our website so that patients can log in, they can enroll in the program online if we had not outreach to them, and they can also download the same materials that were on the app and review the program in detail. We had Michelle Marble, who was our training manager, and she created beautiful PowerPoints to educate both the providers, the staff, the call center, and how to document all of this information in our EMR, which is key as well. And Ann Garrity, the director of analytics, created the patient report, which gave us the patients to outreach to, and that was based on the criteria that the team put together initially. So while that sounds all well and good, there were some challenges that we encountered along the way. And again, this was something that was very new to everybody here at WestMed. We did not anticipate supply chain issues. That was a direct impact of the pandemic. We had originally planned for one blood pressure monitoring device and had to switch midway through to a second device when some of the feedback from patients and providers was that the device was not so accurate. However, based on conversations and the team coming together, we were able to address this issue swiftly and efficiently. And the vendor presented us with another device that we were able to test in-house. We proved that it was accurate, and the patients had a seamless transition from one to the other. We were also extremely fortunate that we had a tremendous patient engagement from the beginning. They wanted to join RPM, and as Patricia, Dr. Kaliag mentioned, it was almost 50% that I think wanted enrollment. And that was great, but I think what we would recommend going forward would be to start on a smaller scale, work out all of the kinks from the beginning to the end in terms of all of the moving pieces before we ramp up to a larger population of patients and incorporating more than one device. The purposes of addressing all of these possible issues or concerns, I think, is important because we want to prevent other people from making the same mistakes or from just the learning things that we had along the way. The biggest piece of this, I think that we all feel as a group, is provider buy-in. We did educate the providers initially. We went from site to site and we showed each provider what the devices look like. They can play with them, they can look at them, they can test them. We did that with the nurses and the doctors, as well as the nurse practitioners. And while we tried to provide as much education as possible about remote patient monitoring, what it is and what the plan was, I think going forward, if we had established more structured and regular follow-up with them in terms of just maybe weekly touching base to address concerns or questions or any issues that may have come up, it could have been a little bit better. But again, it's a work in progress. And if mistakes weren't made to happen, pencils wouldn't have erasers. So I think at this point, the second approach that we did take was, when we learned from that, was that have the provider buy-in was important. We created cards for them to give to their patients when they were in the office that explained what RPM is. So if a patient had an elevated blood pressure at that time, the provider would talk to them about the program. They would give them the card, and the card would show the patient how to enroll or who to call. And at that point, we did see an enhanced enrollment as well as improved provider buy-in at that point. And with that, I'll hand it back to Dr. Kalia.
Yeah, I think we wanted
just share with you, again, I think the patient adoption of it was very easy, and you, as physicians out there, you might not be aware that your health carriers are outreaching to your patients. So we did speak with our carriers and ask them to please not do that and allow us to do it, as we felt that we had a much more integrated approach if a patient should have a problem, since we were the healthcare provider. And if the carriers were doing that, it would interfere and add another step. And we wanted your first run of this program, you want to have the faith and buy-in of your patients. And so if the carrier was doing it, that might not have been as seamless. I think Diane and Sandra and Althea and Rebecca and the entire team, Kelly, have done an amazing job. This is a huge lift. I think the upside for the outcomes, first for our patients were, when the devices were working, we're thrilled with it. In fact, we really saw the uptake in patients taking their blood pressures, which was part of the goal, was to get people used to taking blood pressures on their own between visits. That's been very successful. Dr. Kesh is going to speak to more of the clinical outcomes that she saw in her own experience. But I think we're pleased with where we've come so far. There's been a lot of learning along the way. There's more to come and learn. We believe that this program is going to grow. When you speak to vendors, they will tell you the upside financially is huge, which it is. It's just we saw it because the patient excitement over it was enormous, and we did have to pull back. And when we do get it going, I think it will be a tremendous way for us to improve outcomes, bend the cost curve, and also generate revenue to help our other outreach programs. And at that point, I will hand this over to Dr. Kesh, who's going to tell you about a really exciting program that did require pretty intensive outreach, and for which we are doing programs like RPM, so we can fund this program, which was just excellent in its outcomes and results. So, Dr. Kesh.
Thank you, Patricia. Good morning, everyone, and thank you, Mark, to you and your team for facilitating.
Hold on, we
yep.
can't hear you, Dr. Kesh. Hold on one second. Is that okay?
How's that?
Yep.
Good? All right. Thank you for the dream team's work on RPM. And as Dr. Kaliak mentioned and Diane referenced, RPM is a wonderful complement to kind of a robust offering. And what I wanted to kind of take you and the participants on this call through was a little bit of background in terms of what we've done with hypertension management at WestMed over the past several years. So we, as with many private medical groups, participated in the American Medical Group Association's Measure Up, Pressure Down program, which I think most of you are familiar with. This ran for several years, 2012 to 2015. And as with other practices, the way we kind of branched this program out and really introduced this initiative was to template out the approach. So really to standardize care, we used templates in our electronic medical record that helped guide providers to appropriate decision points in the management of their patients. So for example, directing them to first-line medications for treatment of hypertension. We also kind of socialized the program through the IM division meetings. We had internal medicine division meetings regularly where the AMG initiative was introduced and socialized. And as with most programs that we and other practices have introduced, we used a bonus metric to motivate provider participation and really get the teams going. Our peak performance in the AMGA initiative was 74%. And that's the hypertension control rate in our practice that we measure. And our measure of that is basically what percentage of our patients who have a primary care provider at WestMed achieve a blood pressure control of less than 140/90. Now, as with most programs, and I think most of you who participate in hypertension control programs know this, measuring your performance is a bit of, it's kind of like chasing a moving target. So we really go by the last documented blood pressure. The problem with that and some of the limitation with that, and I think most of you are familiar with this, is that if a patient, if their last encounter in the practice was, for example, a colonoscopy or an urgent care visit, their blood pressure will be elevated as a result of the stress of the encounter. And so you're not always getting an accurate depiction of whether the blood pressure is controlled. One of the things that we really look at is the overall control rate, but we also look at control rates when patients are seen by their internist. And I'll speak a little bit more to that point later. But with the AMGA program, the peak hypertension control rate we achieved through that program was 74%, which is great. The next thing we did, and this was pre-pandemic, starting at the end of November, at the end of 2019 and moving into 2020, was we implemented this curriculum that the AMA put forward called Steps Forward. And it's a series of toolkits that they put on their website, which I'm sure many of you are familiar with this, but if you're not, I strongly encourage you to check this out. That basically helps structure the visit. It helps standardize care. It helps move your practice toward best practice around management of a chronic condition. We enrolled about 1,200 patients into this approach. It was really a team-based care approach. And it kind of concluded at the beginning of 2020 for reasons that are obvious to everyone. The pandemic was starting at that time. And as a result of that initiative, we took that group of 1,200 patients with uncontrolled hypertension, and we achieved control in just over half of them, which is a pretty remarkable impact. Our overall control rate for the practice at the end of that initiative in February of 2020 was 77%. So we had moved from a peak control rate of 74% to a peak control rate of 77% after both of those initiatives. That obviously is not kind of where we want to be as an organization. We pride ourselves on providing the highest level of care at WestMed. And we set our sights on really having a control rate of 85% as our goal. So at that point, we started, while we were contending with the pandemic, we started to think about what are other approaches to providing a higher level of care for hypertension. And around this time, we started to discuss in our leadership team this idea of the integrated practice unit. Not all of you may be familiar with this, but this was a concept that was initially introduced by Michael Porter and Thomas Lee in 2013 as a key component of what they build as the strategy that will fix healthcare, which is a pretty bold proclamation for anyone to make. And so there was a lot of interest in how they were going to support that assertion. So an integrated practice unit, or IPU for short, is defined as bringing multidisciplinary teams together and structuring them to meet the needs of a well-defined group of patients, usually with similar conditions, over the full cycle of care. So how do you compare this to the traditional healthcare delivery system? So in a traditional healthcare delivery system, which is really what we had at WestMed before we started these IPUs, you had basically each provider doing what they did kind of siloed. So some internists were much more proactive about managing their patients' hypertension. They would be more aggressive about the medication management. They would bring their patients back in a more timely way to have their blood pressure rechecked. And that's all wonderful. And they enjoyed great control rates for their patient panel. And then you had other providers who were a little bit more relaxed. Patients were kind of left to reschedule their follow-up at their own discretion. And so you saw a lot of patients who were kind of not brought back in a timely way, and their hypertension control rates were not quite where we wanted them. The concept of an IPU really shifts to one where there's ownership, there's shared ownership of the problem by a group of people who are committed to moving the bar on that problem. And that's really a change in mindset from what we saw happening in our organization and from what I've seen happen in other medical groups. And there are various examples of IPUs that currently exist, and we'll speak more to that point later. But I wanted to speak to the central tenets of an IPU because I think that really helps illustrate how this is different from the care delivery model that we've seen in place and that we see in place at many practices. So the key components of an IPU: one, it's organized around a medical condition, in this case, hypertension. Two, care is delivered by a dedicated multidisciplinary team. And I'll get to who the components of our team are in a bit. Three, providers identify themselves as part of this unit and distinct from the department. This is an area that we struggled with a little bit, and I'll speak to that as well. Four, that the team takes responsibility for the full cycle of care and that all the support services really that the patients require. Part of the IPU is to acknowledge really that each patient is different and the care needs of each patient is different. And I think that's what you see particularly with hypertension. Every patient comes from a different background. Some patients have more support than others. The degree of health literacy differs from patient to patient. And to really have an effective offering, you have to, one, acknowledge that, and two, be prepared to address those gaps. And those gaps differ from patient to patient. Five, that the care model includes patient engagement, education, monitoring, adherence, and follow-up. And that's where RPM became a component of this larger offering. Six, that there's a single management and scheduling structure, that the team is co-located. There's a team captain that's responsible for overseeing our progress. Obviously, that we're measuring outcomes, processes, and costs using a common platform. And that, of course, that the team meets regularly to discuss outcomes and processes. And finally, and what I think is most important, that the team accepts overall accountability for outcomes and costs. And that's where I think, this concept of accountability is one that is something that I think most places struggle with. Who owns the problem, right? Is the ownership kind of dispersed across each individual physician and their care team? And that's kind of the traditional old mindset. Or is the ownership for the problem something that's shared across teams and by one cohesive unit? And that's really kind of what we aspire to do. Okay. Next slide. All right. So before the IPU, as I mentioned, providers kind of managed their own panels. There was variability in how often their patients were recalled. There was this concept of clinical inertia, which many of you may be familiar with. It's basically what happens when you have a patient with high blood pressure in front of you. And you've all seen this. The provider tells the patient, we really need to work on your hypertension. I want you to work on your diet, your exercise. And you see that sort of advice being given at each visit time and time again. And what happens is that that patient's blood pressure remains uncontrolled across those visits. And there's this concept of when are we actually going to intervene on this patient's blood pressure? There was variability in nursing protocols. Some nurses really kind of measured blood pressure the right way every time. Other nurses, were following different approaches, which were not optimal. And there was variability in educational material that was made available to the patients. And again, a lot of this was dependent on what the provider's individual preference was. So what did we do in the IPU? Althea, we're ready for the next slide. All right. So in the IPU, we coordinated a team. So our hypertension team in the IPU consisted of the primary care provider, a registered nurse who really provided a lot of the touches between visits, as opposed to RPM, a remote patient monitoring program. The RN is positioned to actually provide education about the disease, help troubleshoot when a patient is not adhering to a medication regimen because of side effects, why that's the case, and really provide a level of medical education that a care coach who is not clinical may not be able to provide. And so that's where the programs become very complementary. The LPN, obviously the nurse working with a provider at WestMed, most of our internists work with LPNs as opposed to medical assistants. We have nutritionists, we have several dietitians in our practice who we brought into the team as really kind of focusing on hypertension and what are the dietary guidelines around hypertension. An important part of this was making the dietary recommendations something that patients could actually apply. We all know, I think most of us know what a healthy diet is. But finding a way for a patient who may not have the economic resources to buy kind of the high-end dietary products that are out there, kind of working with them to figure out how do you make a grocery list that's actually affordable and helps you improve your blood pressure control and is palatable and is something that you can make for your whole family. That's a challenge. And I think that's something that our nutritionists do a really great job with. Our case management department, I can't say enough about them. They really work with patients who have gaps in care that we don't always identify when I, as a physician, am sitting with a patient in front of me. So patients don't bring those problems to our attention all the time. Hardships in finances, in transportation, other people in the family that they need to take care of so they can't take care of themselves. These are issues that are real, that we aren't often enough aware of, and that need to be addressed by the care team. And that's where the case managers really got involved in and kind of address those needs. We have the luxury of having two clinical pharmacists in our practice. They were able to work with patients who are identified as being non-adherent to medication therapy to figure out why. A lot of times, when a physician or a provider sits down with a patient and prescribes a regimen, they don't always have the time to kind of go through what are the side effects. Is the diuretic going to make me get up in the middle of the night and use the bathroom 3 or 4 times? Is that something that I'm actually going to take? Or is that something that a pharmacist maybe can sit down with me and discuss timing of that medication so that I can be compliant with it? And they also helped with a lot of patients who had trouble affording some of the medications. There are certain pharmacies in our area that do free home delivery, that can synchronize medication refills so that when a patient goes to the pharmacy, instead of having to go 2 or 3 times a month, they're going 3 times a year. So our clinical pharmacists were an important part of our armamentarium. And then our outreach medical assistant. And so we really only had one outreach MA who worked on this program. So in terms of resource utilization, it was kind of a minimal expenditure for the program. In terms of co-location of care, and remember, co-location of care was an important part of an IPU. You got to have the team all in one place. And this was something that we prioritized even while we were dealing with the pandemic. And we set up our COVID protocols so that this sort of co-location and bringing the team together was doable. We decided to use our White Plains location, which was actually the original location of Westmed Medical Group 25 years ago. And this site actually has 18 primary care providers, and we co-located the rest of our team at this site. When we started the IPU, and that was earlier this year, believe it or not, started in March of this year. So this was a rapid fire intervention. We identified the team members, the roles, we discussed the IPU. We really made them commit to this concept of an enhanced delivery model. So in the interest of time, I'm going to run through these next few slides quickly because the key slide is the results slide. So we applied the steps of AMA Steps Forward into planning the pre-visit section, the visit section, and the post-visit follow-up. And we defined rules for rooming, the provider, and the visit close. Go ahead. So these slides, I believe Mark will make them available to you because I think there's helpful information on all of this. But there were certain components of the pre-visit call that were essential to getting patients to the visit and prepared in a way to have a constructive visit. Go ahead, Althea. In terms of what happened at the visit, the nurse played a key role. And I'll let you folks read this. I don't need to read what's in these slides. The provider's role was well defined as well in terms of promoting the goals, defining the goals, telling the patient how to reach those goals. And as Patricia had mentioned earlier, the key thing and I think this point has been underscored a couple times, the main way to get programs like RPM to work is to have the provider endorse it. And that's what we've seen time and time again. We've done a lot of emails, a lot of kind of outreach. And yes, I see the message. The slides will be available. Don't worry about reading everything. The key factor is when that patient is in front of their physician or their NP. If the provider says this is a program that's worth your doing, they will do it. And that's what we've seen time and time again. You got to get your providers on board. If they endorse these programs, the patients will engage. Go ahead, Althea, to the next one. We had steps for closing the visit. And again, we'll give you these slides so you can go through them. And then the RN would call patients after the visit to assess their understanding and really bridge those gaps in understanding. Let's get to, these are the different roles. And I think I spoke to most of this information before. So the results of the IPU, and this is something that we as an organization are very proud about. We matched our IPU patients. There were 1,200 patients that were targeted for this program. They were matched on age, sex, comorbidities to patients at non-IPU sites. So at sites in our practice that did not participate in the IPU. We did our analysis at the conclusion of a 3-month period. So this IPU, believe it or not, we got all this together at the beginning of the year. The IPU started in March and it concluded in June. We achieved hypertension control in 64% of our IPU patients compared to 44% of non-IPU patients, which, as most of you who look at these hypertension studies know, is a dramatic effect. 76% of the patients had at least one appointment with their internist compared to 55% of non-IPU patients. And among patients who were seen, 76% of patients achieved hypertension control compared to 69% of non-IPU patients. Overall, hypertension control measures, hypertension control that we measured for patients who were in the IPU compared to patients who were not in the IPU increased from 82% to 90% of the patients over that 3-month period. I mean, I thought I was being a little bit overly optimistic when I said we're going to get hypertension control to 85%. I never thought we would reach 90%. So this intervention really, really knocked it out of the park. And I think RPM is going to be a wonderful supplement, and we're already seeing the benefits of RPM as a complement to the IPU. But I think this program really demonstrates that you can achieve excellence in hypertension control, and we're now branching it out. And this just illustrates how the IPU did compared to our other programs, which I referenced earlier. You really can achieve excellence in hypertension control with a program like the IPU and with wrapping RPM into it. So Mark, we have probably a couple minutes for questions, but I hope that this gave your listeners a chance to get a good sense of what we do at WestMed with our hypertension programs.
Thank you very much, Dr. Kesh, Dr. Kaliag, Althea, and Diane. Hey, we do have one question in the chat. So as the project grows, do you envision an analysis of your data by disparity? For example, women over the age of 65 with elevated blood pressure, since heart disease continues to be the #1 cause of death for women.
Yeah, in terms of the IPU, we will be looking at subgroup analysis in terms of which patients, and not just by gender, but also by ethnicity, tend to fare better, tend to fare worse. One of the things that we did kind of struggle with RPM, in which we do have a good fix for, is reaching patients who are in that older cohort and really capturing them. I think when you get patients signed up for remote patient monitoring who are in that older age bracket, getting those in between visits readings is key, and really getting them engaged on the patient education front. But yeah, we will do subgroup analysis to see how those individual cohorts did.
I think it's a great point and a focus of ours, certainly. And I think it's important to emphasize. I think people are looking at that bikini medicine is not really as accurate anymore. And we really do have to look at specific cohorts and look at how women are faring. And we will have to target some of our marketing if we're not seeing with remote patient monitoring that we're getting responses in that age group, certainly.
Perfect. Thank you. Thank you very much for Dr. Kaliag, Dr. Kesh, Althea, Diane, and the whole team at WestMed Medical Group for joining us this morning. It was a great breakout session. Now it's time to let all of our viewers head back to the main room.
All
Please
right.
use the same link you used from the beginning of the summit this morning. And that main room is going to get started at 11 a.m. So once again, thank you for joining us. Thank you, Dr. Kaliak, for sharing your insights with us. And
Thank
if
you,
anyone
Mark,
has
for
any
having
other
us.
questions that you didn't get a chance to ask, you can ask the Heart Association, Lisa Neff, and we can make sure we get Dr. Kaliak to answer that for you.
Perfect.
We hope you have a great rest of the summit. And
Thank you,
thank you
Mark.
very much for joining.
Thank you, Mark. Bye-bye. Thanks, everybody. Thank you.
Oh, my God. We're done? Thank you, Mark.
Thanks, guys. Bye.